ಹಲೋ ರೆಡಿ ಅಲ್ಲ ಅರೌಂಡ್ 3:30 ರೆಡಿ ಇರ್ರಿ ಅಂದ್ರೆ 3:45 ಲಾಗಿನ್ ಆಗ್ತಾರೆ 3:30 ಟೆಂಟೇಟಿವ್ ಹಲೋ 3:30 3:45 ಒಳಗೆ ರೆಡಿ ಇರ್ರಿ ನಾನು ಮೊದಲ ಜಸ್ಟ್ ಲಾಗಿನ್ ಆಗಿ ನೋಡ್ರಿ ಆಮೇಲೆ ಮತ್ತೆ ಕೆಲಸ ಮಾಡಕ್ಕೆ ಅಂದ್ರೆ ಲಾಸ್ಟ್ ಟೈಮ್ ಏನಾಯ್ತು ಇವರು ವಿಲಾಸ್ ಯಾವ್ದೋ ಮಾಡ್ಬೇಕಾದ್ರೆ ಪ್ರಾಬ್ಲಮ್ ಆಗ್ತದೆ ಹಲೋ ಹಲೋ ಮೇಡಮ್ ಹೇಳಿದ್ರಲ್ಲ ಆಯ್ತು ಆಮೇಲೆ ಮೇಡಮ್ ಅವ್ರು ಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡ್ತಾರೆ ನಾವು ಮಾಡಿಸ್ಬಿಡ್ಬೇಕ್ರಿ ಬೆಸ್ಟ್ ಸ್ಪೀಕರ್ನ ಅಲ್ಲ ಅದೇ ಹಂಗಲ್ಲ ಮೇಡಮ್ ಇಂಟ್ರೊಡಕ್ಷನ್ ಮಾಡ್ತಾರೆ ನಾವು ಮಾಡಿ ಮುಗಿಸೋಣ ಅದ ಸಂಬಂಧ ಅಲ್ಲ ಅವ್ರು ಮೇಡಮ್ ಮಾಡ್ಕೊಂಡು ಮಾಡ್ಲಿ ಅದರ್ವೈಸ್ ನಾವು ಇಂಟ್ರೊಡಕ್ಷನ್ ಮಾಡ್ತಾರೆ ನಾನು ಇಂಟ್ರೊಡಕ್ಷನ್ ಮಾಡಿಬಿಡ್ಲಿ ನಾನು ಜಸ್ಟ್ ನಿಮ್ಗೆ ಕೇಳಿದೆ ಅಷ್ಟೇ ಯಾಕಂದ್ರೆ ಇವ್ರಿಗೆ ನಾವು ಹೇಳಿ ಕೊಡಂಗಿಲ್ಲ ಅದು ಇವ್ರಿಗೆ ನಾವು ಹೇಳೋದು ಅದೇ ನಡೀತದೆ ಅಂತಂದ್ರೆ ಅಷ್ಟೇ ಮೇಡಮ್ ಏನು ಸಿವಿ ಐತೇನ್ರಿ ಮೇಡಮ್ ಒಂದು ಸಿವಿ ಇತ್ತು ಕಳಿಸ್ಕೊಟ್ಬಿಟ್ರಲ್ಲ ಸುಮ್ಮನೆ ಎಚ್ ಓ ಡಿ ಏನ್ ಪ್ರಿನ್ಸಿಪಲ್ ಅಷ್ಟಾಗಿ ಬರ್ತದ ಬಟ್ ಬಾಕಿ ಏನ್ರ ಅವರು ಸ್ವಲ್ಪ ಇವನು ಇರ್ತಾವಲ್ಲ ಅವು ಸ್ವಲ್ಪ ಇದ್ರೆ ಕಳ್ಸಲ್ಲ ಸ್ವಲ್ಪ ಕಳ್ಸಲ್ಲ ಸಿಗ ಕಳ್ಸರಿ ಜನ ಎರಡು ಹೇಳ್ಬಿಟ್ಟು 3:30 3:45 ಹಲೋ ಏನಿಲ್ಲ ಅದು 3:30 ರೆಡಿ ಇರ್ರಿ ಅಂದ್ರೆ ಏನಾಗ್ತದ ಲಾಸ್ಟ್ ಟೈಮ್ ಲಾಗಿನ್ ಏನಾದ್ರು ಇಶ್ಯೂ ಆಗಿರ್ತಾವ ಲಾಸ್ಟ್ ಟೈಮ್ ಇವ್ರಿಗೆ ವಿಲಾಸ ಯಾವ್ದು ಹಂಗಾಗಿತ್ತು ಅದೇ ನೀವು ಟೆಂಟೇಟಿವ್ ಲಾಗಿನ್ ಆಗಿ ಆಮೇಲೆ ಮತ್ತೆ ಕೆಲಸ ಮಾಡ್ತೀವಿ ಸ್ವಲ್ಪ ಬರೆಯ ಮಾಡಬೇಕು ಆಮೇಲೆ ಸ್ವಲ್ಪ ಡೀಟೇಲ್ ಆಗಿ ಹೋಗ್ರಿ ಇಟ್ ಇಸ್ ಲೈಕ್ ಮೇನ್ಲಿ ವಿ ಆರ್ ಪ್ರಾಕ್ಟೀಸ್ ಬರ್ತದೆ ಲೈಕ್ ಕೇಸ್ ಸ್ಟೋರಿ ಶುಡ್ ಬಿ ಡೀಟೇಲ್ ಆಸ್ ಫಾರ್ ಪಾಸಿಬಲ್ ಮನ್ ಮಾಡಿದ್ ನೋಡಿದ್ರೆ ನಾನು ಓಕೆ ಮೇನ್ ಫೋಕಸ್ ಆನ್ ಲೈಕ್ how there was a problem then how we solve it ಸ್ವಲ್ಪ ನಡು ಗ್ಯಾಪ್ ಕೊಟ್ಟು ಹೇಳಂಗೆ ಸ್ವಲ್ಪ ಮೇನ್ಲಿ ಸ್ಟೋರಿ ಶುಡ್ ಲೈಕ್ ಸ್ಟೋರಿ ಹೌದು ಅವು ಇವ್ರು ಏನಾದ್ರು ನಮ್ಮ ಇವರು ಜಾದವ್ ನೋಡ್ತಾರೆ ಡೈರೆಕ್ಟ್ಲಿ ಪುಟ್ ಅನ್ MRI ಪಿಕ್ಚರ್ ದೆನ್ ವೆಂಟ್ ಆನ್ ರಿಟ್ರೋಸ್ಪೆಕ್ಟಿವ್ಲಿ ಗೋಯಿಂಗ್ ಫಾರ್ ಇಟ್ ಅದು ಇಟ್ ಡಸಂಟ್ ಅಂದ್ರೆ ಇಟ್ಸ್ ಓಕೆ ಫಾರ್ ಹೈ ಅಂಡ್ ಪೀಪಲ್ ಬಟ್ ಎಸ್ಪೆಷಲಿ ಫಾರ್ ಪ್ರಾಕ್ಟೀಸ್ನರ್ಸ್ ಅಲ್ಲ ಏನಾಗ್ತದೆ ವಿ ನೀಡ್ ಸಮ್ ಕೇಸ್ ಟು ಬ್ಯಾಕ್ಗ್ರೌಂಡ್ ಅದು ಮಾಡಿ ನೋಡಿದೀನಿ ನಿಮ್ಗೆ ಮಾಡಿದ ಪ್ರೆಸೆಂಟ್ ಮಾಡಿ ನೋಡಿದೀನಿ ಇಟ್ಸ್ ಗುಡ್ ಮಾಡ್ರಿ ಅದ್ರ ಸ್ವಲ್ಪ ಜಸ್ಟ್ ಕೆಲವೊಂದು ಸಮ್ ವಾಟ್ ವೀಸ್ ಪ್ರಾಕ್ಟೀಸ್ ಯಾರು ಮೆಸೇಜ್ ಹಾಕಿದ್ರೆ ಗುಡ್ ಹೌದೌದು ಹೌದು ನಿಮ್ಮ ಇವನು ಟೀಚರ್ ಅಲ್ಲ ಹಿ ವಾಸ್ ಹ್ಯಾಪಿ ಗೊತ್ತು ಇಲ್ಲ ನಾನು ಕರ್ನಾಟಕ ಗ್ರೂಪ್ ಎಲ್ಲ ಗ್ರೂಪಲ್ಲಿ ಹಾಕಿದ್ದೀನಿ ನಮ್ದು NNF ಗ್ರೂಪ್ ಒಂದೈತಿ ಪ್ಲಸ್ ನಮ್ ಬೆಂಗಳೂರು ಪ್ಲಸ್ ಕಂಬೈಂಡ್ ಒಂದೆಲ್ಲ ಅಕಾಡೆಮಿಷನ್ ಗ್ರೂಪ್ ಒಂದೈತಿ ಅಲ್ಲಿ ಒಂದು ಕೋರ್ಸ್ ಅದಾವ. ಆಮೇಲೆ ಇವಾಗ ಯಾವುದು ನಮ್ದು ನಾರ್ತ್ ಕರ್ನಾಟಕ ಕಂಪ್ಲೀಟ್ ಇವು ಏರಿಯಾ ಎಲ್ಲ ಅದಾವ. ಹಾಕಿದ್ವಿ ಒಟ್ಟು ಸ್ವಲ್ಪ ಆದಷ್ಟು ಮಟ್ಟಿಗೆ ರಿಲೇಟೆಡ್ ಇಲ್ಲ. ಅಲ್ಲ ಹೋಗಿ ಹೋಗಿ ಓಕೆ. Hello. Yes. 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 Correct. Yes. Yes. Okay. Okay. I seen your mail. I'll try to log in. I'll ask her to sign up. Okay. Hello. Why is it breaking? So I've seen your mail also. There's a network issue. Hello. Okay. I have seen your mail. I'll try to ask her to log. Okay. Sign up for it. Now I'm in meeting actually. I'm a doctor, so I'll ask her to sign up. It's okay. Thank you. ಸೈಡ್ ಸರ್ಸಿದ ಬಂದ್ ಮಾಡ್ಬಿಡಿ ಆ ಬಾಕ್ಸ್ ಅದ್ರ ನನಗೆ ಇಟ್ಬಿಡಿ ವೈರ್ ಸ್ಟಿಕ್ ಇಟ್ಬಿಡು. ಹೆಂಗಿಲ್ಲ ಫೋನ್ ಬಂದಿತ್ತು ತಗೋಬಿಡಿ. ಏನಾಯ್ತು?
ಏನಿದೆ ಸರ್ ಬೆಳಿಗ್ಗೆ ಮುಗ್ದಾನೆ
ಏನ್ ತಕರಾರು ಐತೇನ?
ಏನಿಲ್ಲ ಸರ್ ಬೆಳಿಗ್ಗೆ ಮುಗ್ದಾನ ಮತ್ತೆ ತೋರಿಸ್ಬೇಕಲ್ಲ.
ಬಾವಲ ಏನ್ ಬಂದಿಲ್ಲ?
ಇಲ್ರಿ ಸರ್.
ಮುಂದಿನ ಸರಿ ಸರ್ ಬ್ಲಡ್ ಒಂದು ಚೆಕ್ ಮಾಡ್ಸಕ್ಕೆ.
ಏನು?
ಮುಂದಿನ ಸರಿ ಸರ್ ಬ್ಲಡ್ ಚೆಕ್ ಮಾಡ್ಸಕ್ಕೆ.
ಮುಂದಿನ ದಿನ ಅಲ್ಲ ಸರ್.
ಊಟ ಮಾಡೋದಿಲ್ಲ?
ಊಟ ಮಾಡ್ತೀನಿ ಸರ್. ಅದು ಇರ್ತದೆ ಏನು ಹುಡುಗರಿಗೆ ಕೊಡಾಕಿದ್ದೀನಿ ಸರ್. ಅದು ನೀರು ಕೊಡಾಕತ್ತಾರ, ಗ್ಲೌಸ್ ಕೊಡಾಕತ್ತಾರ.
ಗ್ಲೌಸ್ ಏನೋ ಬಂದಿಲ್ಲ ಅವ್ರು?
ಬಂದಿಲ್ಲ. ಬರ್ಬೋದ್ರಿ ಸರ್?
ಈ ಸದ್ಯ ನೀವು 12 ವರ್ಷ ಮ್ಯಾಗಿನವ್ರು ಬರ್ಬೋದು.
ಆಮೇಲೆ ಸಣ್ಣ ಹುಡುಗರು ಸರ್
ಇಲ್ಲ
ಹೋಗಿ ಬಂದಿಲ್ಲ. ಬಂದ್ರೆ ನಾವು $3 ಹಾಕ್ಬೇಕು.
ಬಂದ್ರೆ ಹೇಳ್ತೀವಿ, ಅದು ಚಾನ್ಸ್ ಇಲ್ಲ. 12 ವರ್ಷ ಒಳಗಂತೂ ಏನು ಬರಂಗಿಲ್ಲ. 12 ವರ್ಷ ಮ್ಯಾಗಿನವ್ರು.
ಸ್ವಲ್ಪ ನಗಡಿ ಬಂದಿತ್ರಿ ಆಮೇಲೆ ಊಟ ಮಾಡೋದ್ನಾಗ ಉಲ್ಟಿ ಮಾಡಾಕತ್ತರಿ ಮತ್ತ ಸಂದಾಸ ಮಾಡಿದ್ರಿ ಸರ ಮತ್ತೆ ಹಿಂಗ ಏನ್ ಕಕ್ಕದ್ಮೇಲೆ ಮೈ ಸ್ವಲ್ಪ ಕೆಂಪು ಮಾಡಾಕತ್ತರಿ
ಒಂದ್ ಸರಿ ಮಾಡಿದ ಸಂಘ ಸರಿ ಮಾಡಿದ
ನಿನ್ನಿಂದ ಮಾಡಿಲ್ಲ ಅಂತ ಸರ್ ಮತ್ತೆ ಊಟ ಮಾಡೋದ್ನಾಗ ಉಲ್ಟಿ ಮಾಡಾಕತ್ತೀನಿ
ಕೆಮ್ಮು ಐತೆ ಕೆಮ್ಮು ಇಲ್ಲ
ಕೆಮ್ಮು ಒಂದ್ ಜರ ಐತಿ ಸರ್ ಅವ್ರಿಗೆ ಕನ್ನಡ ತಿಳಿಯಂಗಿಲ್ಲ ಸರ್ ಹಾಗೆ
ಉರಿ
ಇದ್ದಲ್ಲ ಸರ್
ಇಲ್ಲ ಮೂಗು ಇಲ್ಲ
ಯಾವ್ದನ್ನ ಮೋಷನ್ ಮಾಡಿಲ್ಲ
ನಾನು 350 ಅಂತ These are current together. Charge. ಈಗ ಅದು ಇದು ಈ ಮಷಿನ್ಸ್ ಎಲ್ಲ ಇದಾವಲ್ಲ ಹೆಂಗೆ ಕೊಡೋದು ಕಡಿಮೆ ಕಡಿಮೆ ನಾಳೆ ಕಸರ್ಲಾಗ ನಾಳೆ ಬಿಡ್ತು ಅಂತ ಅದು ಇದನ್ನ ಬಂದ್ ಮಾಡಿ ಸುಮ್ಮನೆ ನೋಡ್ರಿ ಟೆಲಿಫೋನ್ ಇದು ಇಂಟರ್ಕಾಮ್ ಬಂದ್ ಮಾಡಿ ಸುಮ್ಮನೆ ಅರ್ಜೆಂಟ್ ಬೇಡ ನನಗೆ ಮತ್ತೆ ಇಲ್ಲಿ ಬ್ರೇಕ್ ಆಗೋಲ್ಲ.
Hello, is it audible?
Yes, Vijay. Yes, it is audible. Hello.
Hello, yes, sir.
Hi. Yes, yes, you are audible.
Okay, sir. Shall
You
I
can try
check
screen sharing.
screen sharing once, sir?
You can try screen sharing.
Yes.
Yes. Make it full screen.
Is it
Yes.
visible?
Yes.
Okay.
Visible, visible.
Yeah.
Just move it.
Shall I stop the screen share or shall I continue?
Just move the slides up and down.
Yes.
Okay. Okay. You can minimize it, no?
Yes, sir.
Just stop afterwards. I think you can share up top afterwards. No?
Yes.
Atas berapa kali berapa? Namaste.
Hello, everybody.
Hello, madam.
Good evening. Sorry, sir, in a meeting. So,
Namaskar, ma'am. Namaskar, ma'am.
Namaste. Re. Sorry, it's a little late.
4 o'clock time, ma'am. New time, 5 minutes. NAC inspection, madam.
Ilri, purchase committee meeting. Stretch akonta. From morning we were supposed to have it. Too many things. That's why.
He was responsible for that, madam.
So Kolhapur, how is it?
Yes, madam. Kolhapur is now a bit better now. We had recently flood, and that's a bit disturbed.
I know.
Yes, madam. Now it's all things are going now back on track.
Achha.
COVID cases are also going down, but it's not completely normal yet.
This wave it has never got back to normal. That is the problem.
Yes, madam.
Last time immediately it came down to 0.
Yeah.
This time it's not.
In spite of vaccination, somehow the cases are still there, madam.
It's going to be there, madam. It's like flu now.
Yeah. Yeah, but
it will not be 0, madam. There will be a sprinkling of cases here and there.
I think today's talk will tell us the damage and problem that is happening in newborns and pediatrics.
Yes, it's just like a consequence of infection.
Yeah.
And then we are expecting similar trend now in couple of. The only thing, we'll see what vaccination, everything that it has made.
I know.
Change.
I hope it protects.
Yes.
What we have seen here is the vaccine. I don't know all over the world. This is vaccinated. The people definitely do have a great protection. At least the disease is not so severe.
Yes, madam.
It is everywhere, madam. It is everywhere.
Yeah, that's what I'm saying. All over the world. I don't know with Miss C and Miss N.
Only like.
Any studies are there?
Yes, ma'am. Those who are having any morbidity, they, in spite of vaccination, they get sick. Otherwise, it gives a good protection.
Yeah, true. But we don't know with Miss C and Miss N. Supposing I am vaccinated and have COVID.
Okay.
The pregnant lady can.
Next, I think couple of months we'll get.
Yeah, we'll get some literature on that also.
Yeah.
So much of thing flowing in.
And it was quite introduced early without much trials. So
yeah,
about vaccine itself, we don't know how that antibodies and then fetal effects. But what I will present a lot of problems with COVID in pregnancy itself, madam.
I know.
So they prefer to have at least mother.
I remember last year in March, they were saying not much effects except for few stray reports from Pune and some other abroad, of course. Then slowly it started.
Yes, ma'am.
Placental involvement and other involvement.
Yes.
So a lot to learn about this disease still. I don't know.
It's quite new, madam. It is.
Yeah.
It affects the immune system directly. It's a lot of variable and unpredictable presentation.
That's what we are living in, like a little bit of uncertainty only. Because we really don't know. All other diseases stop. Even H1N1 did not cause so much of havoc as this.
Yes, madam.
So Salgare, whenever you say to start, we'll start.
Okay. We'll 4 o'clock, exactly 4 o'clock to start. Another 2 minutes.
How is the IAP in, Kolhapur branch must be active now?
Yes, madam. This breastfeeding week,
I know.
Everybody is busy with that. A lot of activities and media activity, everything is going on, madam. There's we don't have breast milk bank, so I think a couple of days back we were discussing.
I think every place should have one.
Yes, madam.
Not very difficult to set up. DY Patil, Pune also they don't have.
No, yes, madam. DY they have, madam.
Uh,
They have, madam. DY Patil.
DY
So,
Patil.
Shailaja
We
Mane,
had gone to that Lata Mangeshkar and
Deenanath.
Deenanath.
Deenanath. We had gone to, yeah, we had gone to DY Patil also. Yeah.
Shailaja Mane is managing, madam. See,
Yeah. Yeah, we had gone. Sorry, we had gone. Bharati Vidyapit doesn't have.
Yeah. Here also it is required, madam. Now, but we don't
Yeah,
know.
everywhere it is required. Human
Yes.
milk bank is something that is required.
Now
Only
we are
that,
dependent on that human milk, madam. Neolacta we are getting somehow.
okay.
So that is like pasteurized milk.
Uh-huh.
So it comes from
I know.
Pune, and then we have
Mm.
powder form as well. At least
Oh.
relief for initial management.
Pune is,
That is very
I mean, even home to home delivery they had. Deenanath.
okay, madam.
But yeah, all over the country it has to pick up.
Yes, ma'am.
Right.
we'll start, madam.
Yeah.
Bhavna.
A very good afternoon to all of you. As we continue our case-based discussions, we initially had the neurological manifestations of COVID, then we had cardiac, and today we come to the neonatal part. I welcome you all on behalf of the Belgavi Association of Pediatrics. Today we will have an interesting case-based discussion on Miss N, and I hope it will be very useful to all of us, as day-to-day basis we are seeing so many cases. Without wasting much time, I request our president, Dr. Salgare sir, to introduce our guest speaker and moderator for today. Sir.
Good evening, all. I welcome all the seniors, teachers, colleagues, and friends for this new webinar series of Belgavi Association of Pediatrics. To introduce, today we have got case-based discussion on that is Missy in newborn. And since COVID is a new disease, we are learning many things. So in that, actually, Dr. Madi, working as a neonatologist, they have studied a lot of cases at the end of first wave, when even before the guidelines were announced for the management of Missy. So he'll be dealing with his cases what they have treated in the last 1 year. To introduce Dr. Mansetti madam is a big task for me, because
don't.
has got a huge CV
Don't
of more than around 7 to 10 pages. So I'll try to just say briefly. Madam is a life member of Indian Academy of Pediatrics. Madam, and as we know, Madam was president of the Karnataka State IAP. Madam was secretary also. Madam was president of BA Belgavi Association of Pediatrics, and she was secretary twice. So, and Madam has got national as well as international recognition. So she is pride of our Belgavi IAP. With these few words, I'll ask Madam to moderate this session. Dr. Vijay Mali is a pediatrician and neonatologist. He did his MD from Gujarat at Saurashtra Medical College, and then he did fellowship in neonatology from Manipal University, Bangalore. Then he worked in UK, that is Radcliffe University, Oxford. So there he did his fellowship. Now presently he is the founder and of the there is a Neonatal Advanced Center, and he's associate professor of pediatrics at DY Patil Medical College. So with these few words, I'll ask Dr. Mansetti madam to moderate the session. Thank you.
A very good evening to all. Thank you, Dr. Salgare, for the opportunity and also those kind words. Today's topic, before that, I must say the IAP Belgaum branch is doing a really great job. And by conducting this series of webinars for all the district pediatricians with renowned speakers. As Dr. Bhavna has said, various aspects of COVID have been discussed, but always it is an enigma with this topic today of neonatal multisystem inflammatory syndrome, that is Miss N. I think today, with so many, especially during the peak of COVID infection, what we saw is almost 7 out of 10 mothers would be COVID positive. And babies born to them, invariably, I mean, quite a few of them used to have this problem. We had a huge series, right from term babies to preterm babies, and some of them, I mean, really deteriorating very fast. So the main problem, I think, with Miss N is, especially when it is with preterm babies or low birth weight babies, the compounded factors of other comorbidities like RDS and CNS involvement, and plus sometimes even many a times sepsis, compounding this Miss N. To make a distinction between them, it becomes a difficulty, because we all know that Miss N has to be promptly diagnosed and promptly treated. That is one end of the spectrum of Miss N that we are seeing. And many of the babies, after when they came for follow-up at 2 to 3 weeks, also had some manifestations. The second problem, I think, is the treatment aspect. It's not cheap. So, in fact, when we were planning the third wave, this was our main concern. Dr. Salgare and all of us have whatever forum or whatever platform we could get, we used to put this point that we have to have this treatment at a subsidized cost. The good thing, of course, is most of the newborns do not have this severe infection. But however, when it is present in the neonates, we have to make a diagnosis and treat them early. Clinical challenge for us is the varied manifestations. And today, Dr. Vijay Mali, I'm sure all of us, many of us would have read his article on this Miss N in, I mean, it's available on the net also, and he has done a lot of work on this. So he will be, through case-based series, he's going to enrich us with this topic. So I request Dr. Vijay Mali to take over and enrich us with this Miss N topic with his vast experience. Dr. Vijay Mali, please.
Madam, he is connecting. There was some connectivity issue.
Yes, yes. I think he's gone offline.
Yes, yes. This is the, I think they published the first series, madam, of this MSA.
Yes, yes.
From the Kolhapur.
As recently as July, it was published.
Yes, yes.
So he's got a vast experience, actually.
Yes, madam. They had that first-hand experience. Like they started getting cases
and Kolhapur, it was rampant, actually. I mean, COVID was rampant. So, in fact, even we had about 10 to 12 cases.
Yes,
now, every case we are considering it as a differential diagnosis.
yes, ma'am. Even now,
Not only in neonates, even in pediatrics now.
yes, even last, I think, when there was BIP case presentation, also they have taken these cases.
Dr. Mali, I think we lost you for some time. So over to you, Dr. Mali, without wasting any time.
Madam, we'll start. Thank you very much. Thank you, madam and sir, and all the Belgaum Pediatric Association members for giving me this opportunity. And I will start sharing my screen. I hope is it visible?
Yes, yes.
Yes, it is.
Sorry for that interruption. It's a scary part of online lectures.
I know.
First of all, thank you very much, madam, and thank you, sir, for the nice introduction. So I'll be talking today about multisystem inflammatory syndrome in neonate associated with prenatal SARS-CoV-2 infection. the interesting cases to begin with, and then I will summarize all the cases so far we have seen. So before we could start, because in last, I think nearly 2 years, we have been repeatedly going through the word like inflammation. Same is with adults as well as same is with any complication of COVID infection. So what are the markers of inflammation? We will have a couple of slides to talk about these inflammatory markers. Then we'll go directly to cases. So we know leukocytosis, lymphopenia, and thrombocytopenia is common inflammatory markers. We do check in our routine practice, as well as we look for C-reactive protein. It is not only inflammation as well as infection marker we look routinely. Apart from that, there is hypoalbuminemia, elevated D-dimer levels, elevated ferritin, elevated procalcitonin, interleukin 6, LDH, and aspartate transaminase. So it's a list of inflammatory markers are there, but they were till now of more of research use. But nowadays, because of this COVID pandemic, we need to be very familiar with these inflammatory markers and their normal values. I'll be talking about neonates and their normal value so that it is easier for us to interpret in our routine practice. C-reactive protein, it is normal ranges 0 to 6 milligram per deciliters. Everyone is very well aware of it. And it is made by liver and produced in response to inflammation. Inflammation is the way of protecting tissues if you have been injured or have an infection. Inflammation can cause pain, redness, swelling in injured or affected area. Some autoimmune disorders or chronic diseases can also cause inflammation. Then we have second marker, that is D-dimer, most routinely used, and level in newborn is less than 2700 nanogram per ml. Any hypercoagulable state, the levels significantly increase. And then along with that, if there is a presence of fibrin degradation products, then there is a definite clot formation and fibrinogen deposition, then it is lysed. So level less than 2700 nanogram per ml is considered to be normal. But if you check in a normal newborn, the level is up to 500 nanogram per ml. So a lot of guidelines and revision of this guideline, as of now, they say anything more than 3 times the normal value, high normal value, is abnormal D-dimer in newborn period. And we have ferritin level. This protein that contains iron is a primary form of iron stored inside the cell. The small amount of ferritin that is released and circulates in the blood is a reflection of total amount of iron stored in the body. High ferritin is a consequence of cell stress and damage. So if you can see the range, it varies between 50 microgram per liter up to 147 microgram per liter. This value is predominantly reflected by the maternal ferritin level as well. So we need to be cautious while interpreting these values. If values are less, sometimes it is implicating the maternal low ferritin level as well. So it should be interpreted in context of clinical scenario. Then we have lactate dehydrogenase. Normal range is 290 to 775 units per liter. Enzyme found in almost all body tissues, and it plays an important role. It plays an important role in cellular respiration, the process by which glucose from the food is converted into usable energy for our cells. Although LDH is abundant in tissue cells, blood levels of enzyme are normally very low. However, when tissues are damaged by injury or any disease process, they release more LDH into the bloodstream. So we have the normal range 290 to 775 units per liter in neonatal period. Then we have two cardiac markers. One is NT-proBNP. Normal value is less than 12,000 picogram per ml for initial 2 days, and then less than 6,000 picogram per ml for 3 to 11 days. The B-type natriuretic peptide is a hormone produced by the heart. N-terminal prohormone, BNP, is a non-active prohormone released in response to changes in the pressure inside the heart. Can be related to heart failure, diastolic dysfunction, acute coronary syndrome, or vascular hypertrophy. So it is more specific to the cardiac function and cardiac muscles. And to be more specific, we have troponin I. The value ranges between 0.63 plus or minus 0.58 nanogram per ml. And the cardiac specific troponin elevated in response to any myocardial injury. the importance of this hormone is that it elevates within 48, peak levels reaches in 48 hours, and then it remains there for a couple of hours and then drops steadily over next 6 to 8 days. So it will indicate about acute myocardial injury. Then we have interleukin-6. It was mainly a research tool previously mainly used to detect necrotizing enterocolitis, and the values were 4.7 to 282 picogram per ml newborn, promptly and transiently produced in response to infection and the tissue injuries, contributes to host defense through the stimulation of acute phase responses, hematopoiesis, and immune reaction. So dysregulated continued synthesis of interleukin-6 is a part of chronic inflammation and autoimmunity. So any lesser production or more production itself can be an indication of ongoing immunological disturbance. So with this background, we have, and so crux of all this is that we have a lot of new inflammatory markers, and knowing these markers is not only enough, we should know how the sample should be collected, because all these new inflammatory markers need to be collected very precisely in a lab recommended container, and adequate sample should be there. We have difficulty to collect this sample in extreme preterm neonates, those who are less than 1.5 kg, because sample requirement is minimum 2 ml. For interleukin-6, they expect around 4 ml of blood sample, and it should be processed within 1 hour of collection, and the lab should be very much well acquainted in processing this sample, because errors are very common, especially when the newborn sample, which is almost of the time is having high bilirubin levels, electrolyte sodium levels were high or very low, or sometimes it is hemolyzed sample. So whenever we are considering sending the sample, should be done as per the guidelines, and the lab person should be informed that it should be processed as early as possible. So we'll go to the case 1. So I'll try to go through what we have gone through at the initial stage. So it was an emergency C-section. Mother came in labor with fetal distress, NST abnormal with the decelerations and non-progress of labor, and membranes were intact. It was 35 weeks, male child, 18th November 2020 to be exact, and the weight was 2.4 kg, was appropriate for given age. This is premigravida mother with 31 years and married with 4 years. And antenatally, there was no significant history of any medical or surgical condition or any infection or any suspected infection. However, there was a high-grade fever with rash for 2 days before the delivery, when all the investigations were done, and that was normal. In fact, the obstetrician were waiting to get all the reports done before delivery. So because that time it was almost a mandatory test to have RT-PCR before any delivery. So dengue, typhoid, everything has been done for the mother, but all reports were normal, and mother was otherwise non-toxic. And baby, soon after delivery, required stimulation at birth to cry, and Apgars were 8 and 10. On general examination, so it was normal temperature, good heart rate with tachypnea, respiratory rate of 80 per minute, minimal grunting and distress noted after 5 minutes. Capillary fill time was less than 3 seconds, good saturation, and antifontanel was normal, no external anomalies were noted. The baby was shifted to neonatal ICU because mother had history of fever and the rash with it could be a stress, or it could be some septic, because mother was there for 2 days. So septic work was done, which was normal. Antibiotics were started as per the protocol and kept on CPAP in view of grunting and distress. Saturations well maintained with 40% oxygen. And the chest X-ray was done, which was suggestive of transient tachypnea of newborn. And I could not get hold the X-ray, which was quite old. And then we have initial blood report on day 1 with hemoglobin 17.6, total count of 15,800, good platelet count. Rest of the parameters looks good. We have repeated the similar test on day 3, and apart from high jaundice, rest of the reports were normal. Day 2 was shifted from CPAP to nasal prong oxygen, and feeds were started on day 2. It was a preterm formula feed was started with 5 ml 2 early feeds because baby was good weight, started good amount of feed, was stable hemodynamically. On day 4, we noticed there's abdominal distension, and NG showed a brown aspirates. And because of brown aspirate and distension, decreased bowel motility, was kept ill by mouth. in spite of 2 days of nil by mouth, continues to have persistent abdominal fullness with the decreased bowel movements. Considering necrotizing enterocolitis, plan to keep nil by mouth for another 3 days, and baby continues to have intermittent bleeding with abdominal distension, which was present in spite of keeping the child nil by mouth. Was stable hemodynamically all the time, and vitamin K was given. So this was the day 4 X-ray we had, and we could see almost nearly there's a minimal gaseous shadows are seen, and it's not normal abdomen on day 4, and an X-ray looks normal. And we have on day 7, almost it is a gasless abdomen, and abdomen is very distended with persistent brown aspirates. So we, on day 7, because we kept the child nil by mouth because not responding, and the day 7 we had this kind of bleed, so almost profuse melena, and child got very unstable after this. Otherwise, before till that event, child was very stable. And then we could notice on almost on day 6 or 7, there was small lesions in the oral cavity, which were looking very red and shiny lesions. There was some lip edema as well present. Mucocutaneous junctions were eroded. So we thought because child was not feeding, so we just we thought we'll keep close monitoring of these symptoms. And there were some rashes over the body, and it was not typical of erythema toxicum. And then what typical finding we saw on nearly after 1 week of life is that edema and skin peeling on both the feet. We never see this kind of lesion in newborn. We see edema because of hypoalbuminemia, that too in a preterm neonate. This is just nearly late preterm neonate with good weight. Initially, we thought it could be because of hypoalbuminemia. We are not feeding the child, maybe cause of edema, but skin peeling was quite new to us, and it was seen on both the legs. This was the child who gained nearly around 300 to 400 gram weight in 10th day of life, by 10th day of life, and edema was present all over the body, and rashes were there. Otherwise, child was stable hemodynamically till the child had profuse melena. And then I will go through the investigations from day 5 onwards. Till day 4, we kept NBM. Day 5, initial reports were normal. So day 5, we repeated routine blood test. At that time, hemoglobin is 18.7 and CRP was 26.77. Considering it is a necrotizing enterocolitis, a gram-negative infection started on antibiotics, was already on antibiotics. We upgraded the antibiotics, and then subsequent CRP continues to rise. And on day 7, when child had bleed, hemoglobin dropped to 7.7 with the high WBC count, and platelets were 67,000, which is very difficult to explain. Just with 67,000 platelets, this much of bleeding is quite not possible to explain. At the same time, in any necrotizing enterocolitis, we see when we stop the feeds, they really respond very nicely because it's an admitted child. And once we see any bleeding or abdominal distension, we immediately stop the feeding. And it's quite unusual to have bleeding in spite we kept the child nil by mouth. CRP was 28.3 and rest of the parameters are normal. And we did LFT, RFT on that day, and it was normal, but we didn't do PTA, PTT, INR on day 7 because hemoglobin was already low and child was looking very sick. So instead, we prefer to give fresh frozen plasma because we're just worried about ongoing problem. And the D-dimer was done, subsequently was 3800. So we continued our care and required intermittent CPAP for distress and desaturation. And this distress and desaturation is not because of respiratory problem. In fact, it is because of abdominal distension and difficulty because of generalized edema. Fresh frozen plasma and platelets were transfused, and we give PCV twice for low hemoglobin, and child was otherwise stable. After the resuscitation with the blood products, hemoglobin came up and child looks otherwise stable. Child had one episode of convulsion type movement, was loaded with phenobarbital twice, but after that, such movements were not noted, so we never continued on any antiepileptics. So on continuation of the care, we got culture report after 3 days. It grew no organism. On day 10, we had like after transfusion, hemoglobin came up, platelets, WBC was still higher, platelets came to 39,000. And because we we were seeing these unusual symptoms, and that time similar cases were around, and we are listening about inflammation in neonate. So we thought we do COVID antibody, and it came positive. Even though titers are not high, but definitely it is positive. And then retrospectively, we checked the maternal COVID antibody status, which was also positive. But being it's a first time case we are seeing this, we are very reluctant to do anything at this stage because child was hemodynamically stable and things were under control with blood transfusion and fresh frozen plasma. So we thought we'll just wait, because we were not very sure about what to do at this stage. And we thought maybe in DIC, maybe we are missing some organism. So we continued on broad spectrum antibiotics. And then on subsequent 3 days, WBC count has gone up to 44,580. And could be a lab error, but definitely its counts were definitely high. Platelet dropped to 20,000, CRP is still higher. And we repeated D-dimer on day 14 because the bleeding was still there. It was not completely under control, and the D-dimer level is 6,350. So this time we were really concerned that we may be dealing with a disseminated intravascular coagulation, and maybe because of some other cause rather than NEC. And a subsequent PT APTT was done, which is significantly deranged with APTT 180, and INR value was normal, but PT value was 16.2. So this time we were very sure that we need to act immediately, otherwise we may lose the child. And echo was done, and because every time we are knowing that cardiac involvement is common in this condition, so we looked at the heart and it looked normal on day 15. So day 16, the platelets, in spite of platelet transfusion, dropped down to 9,000 and CRP was 59.7. So that day we decided we have to, after discussing with our colleagues and going through the literature, so we decided that we will start some treatment for, mainly considering it is like a Kawasaki type illness. So we have decided to start with regime. So child was started on day 16. So symptoms were started on 2nd week of life, almost on 10th day of life. And we were waiting for 6 days just to see, because we were not very confident about that. And then on day 16, we treated with methylprednisolone for 3 days as 10 milligram per kg per dose for 3 days as a bolus dose. And after discussion with hematologist, we gave low molecular weight heparin subcutaneously 2 milligram per kg for 1 week in this child, and IV immunoglobulin was given as 1 gram per kg per day for 3 days, because we were very surprised to see that within 24 hours, the child started showing good response. And eventually, I was not very sure how long to give immunoglobulin, so 3rd day immunoglobulin as well given. And echo was repeated on day 18 because most of the time in all the reported cases in pediatric, there was a cardiac involvement as well. So we did repeat echo on day 18 after 3 days, and then there appeared a coronary appears dilated, even though just score was not significant, but there was no aneurysm, but coronaries appears dilated. So continued. So after the treatment, the platelets remained on the lower side, CRP gone up slightly higher, but child showed good clinical response in terms of decreasing edema and rash all over the body. And then CRP continued. I will summarize all this in one slide. So when we put all these platelet counts in one graph, what we have seen is that platelets were quite good in initial phase. And then once child had inflammatory reaction, which was started, then dropped on day 4 onwards. And lowest platelet we recorded was 9,000. In spite of starting the therapy on day 16, platelets continues to remain on lower for nearly 1 week and then came up. And at day 37, platelet came normal to 212,000. So it is quite long for any, because most of the time in infection, everything we see platelet responses, it will not take that much time to come up. But here we may have started the treatment quite late. So it took a long time for the platelets recovery. Same is case with the C-reactive protein. on day 4, CRP was 26.77. And then we have treatment on day 16, 17. That time CRP was 59. For next couple of days, CRP gone up to 75 and then slowly dropped down. For day 37, CRP was 12. So it is a long period of elevated C-reactive protein. The child responded clinically well. So we continued on antibiotics and supportive care. So before the therapy and after 3 days, I think this is the 4th or 5th day of starting methylprednisolone and IV immunoglobulin. This is the picture. We could see the rash is completely, the oral cavity appears completely normal. The rash disappeared on second day itself. And the edema on 5th or 6th day, edema has decreased. Everything, the leg was looking quite normal. This is the other leg. And it was very rewarding for us because it was such a stress for 2 weeks we are going through. And especially when the parents, grandparents were a doctor couple, it was very tough time for us to explain them. And when we saw this drastic response, we were very convinced that we were dealing with some autoimmune or inflammatory reaction rather than a routine infection or necrotizing enterocolitis. So before treatment, after treatment, child has showed a significant weight loss and was looking much better in terms of activity and general appearance. So overall treatment we did so far was on 7 to 11 day, child required CPAP for abdominal distension and increased breathing effort. 23rd day required CPAP for minimal distress. Antibiotics were given for total 21 days and heparin for 1 week, which was guided by D-dimer level. We stopped heparin when the D-dimer level is less than 1000 and feeds restarted after 2 weeks and graded to full feeds. So far during that period, PCV was 5 times PCV was given, FFP given 7 times and platelets 2 RDP, 1 STP was given. And we stopped giving platelet transfusion because it was not making difference in terms of improving the platelet count. So, and this is the child, we took the follow-up after 6 months and is growing well and is appropriate in terms of neurological development. So we felt really very happy that it was picked up. It was very late pickup, but definitely it was picked up and was treated with available best practices at the time and child responded well. So what we have learned out of it is that high index of suspicion for MIS-N if clinical condition is not improving as expected and inflammatory markers are worsening. Early diagnosis avoid unnecessary stress for doctor and prevent mortality. Real tough time to explain what is MIS-N to relatives, as all the time they tend to think it is COVID, even though we explain them it is not the COVID antigen, it is COVID antibody. Relatives, that time it was so stressful situation for everyone about the COVID, they tend to ask that it is why mother is not having COVID, why still baby suffering from COVID. So it took lot of time for us to explain the relatives. This was first case and this was a good learning point for us. And then we had a discussion amongst ourselves. And then we thought we will keep close monitoring about any such symptoms in future of any newborn. And then subsequently we had another case presented nearly after 2 weeks of the initial case. So this is a full-term neonate with the history of cesarean delivery for previous LSCS. Liker was very clear. Baby cried immediately after birth. Apgars were 9 and 10 and was born on 2nd of December, nearly after 2 weeks of first case, and birth weight was 3.5 kg male child. So we were treating that previous child and same time this child got admitted. Obstetric history is gravida 3, para 2, living 2, and RT-PCR was negative at the time of delivery. Natal antenatal history, no history of any medical or surgical condition or any infection, but there was a history of high-grade fever with rash for 7 days, cause is unknown in the 2nd trimester of pregnancy, and we were not sure about this rash, but grandparents and parents were quite sure there was some rash and it subsided, and that time they evaluated for dengue and it was normal, and COVID was never tested during that time. Feeds established with mother milk and top-up milk, no concern for first 2 days. And then we could notice increased respiratory efforts on 3rd day, tachypnea, grunting, and subcostal retraction, and decreased activity with poor feeding. So initial examination on day 3, I think is where child was very poor cry activity and temperature was normal, but surprisingly in a routine pulse oximeter monitor in maternity, heart rate was between 78 to 140 per minute. We thought it could be because of poor perfusion or child may be in the shock or septic shock. So it may not be picking up all the signals. So child was, and saturation was 74% on room air and 94% with oxygen. Child was immediately shifted to neonatal ICU, and there was a mild skin rash all over the body, not typical of erythema toxicum, and we didn't have the picture of that. But definitely there was a rash all over the body. And because mother had, the child was getting sick on 3rd day, routinely in our practice, we think it could be a septicemia, viral infection, herpes or any intraviral, or congenital pneumonia, congenital heart disease, anatomical malformation, lung or aspiration pneumonia. These were our initial thinking to begin with. So on detailed examination, definitely there was a tachypnea and expiratory grunting, and heartbeat was very much variable between 78 to 140 per minute. So we could check it with ECG, and ECG showed it is 2:1 block. So after discussion with cardiologist, we confirm repeatedly it is definitely a heart block, 2nd degree heart block. And then at the same time, we had blood gas, which showed a respiratory acidosis with hypoxia. So we're a bit reluctant now. We are a bit really worried that it is not just the problem with infection. There may be something else going on. Child is going respiratory failure, maybe pneumonia or anything is maybe there underlying. So X-ray was done on the same day, and the X-ray suggestive of bilateral haziness was there, more on the right side. So we kept the baby on CPAP initially, and subsequently child was ventilated because of worsening of respiratory acidosis. And the child was otherwise stable hemodynamically. At that time, we gave him on dopamine for low blood pressure. So the investigations on day of admission, the investigation report, because we admitted in the morning, reports came in the afternoon. By that time, we had the X-ray ECG with us. And the reports, hemoglobin was 20, WBC count was 18,600 with predominant neutrophilia, and platelet count is 82,000. C-reactive protein was 60.68, and bilirubin is slightly definitely on the higher side. And looking at this picture, we took the detailed history of mother side, whether there was any leaking history, mother had any fever, maternal investigations, but there is nothing to say that it is some rupture of membranes or any maternal infection. So because we were dealing with a similar kind of case at that time in our unit, we immediately did the COVID antibodies, and it came to be 74.39, very high COVID antibody titers. And similarly, we checked for the mother, and she was also positive for IgG antibodies. The D-dimer level was 6,483 nanogram per deciliter. So we're very confident that it is not routine infection. So we tested other inflammatory markers like ferritin, which was 878, interleukin 6 was 14.63, troponin I was 16.8, and LDH was 752. Considering all this in favor of inflammation, child was started on our routine regime. I have reports after that. So we had done the echo on day 4, which was normal. So we made it a practice that any child with a high inflammatory markers will do echo immediately to look for any cardiac involvement, because the TROP-I and LDH were high at the time. Troponin I was high, so we worried about cardiac function, and it was normal. And then maternal COVID serologist showed high IgG titers. So as I explained earlier, so because we had some consensus understanding amongst ourselves that we will treat the children with methylprednisolone as bolus dose instead of like continuous medication. Low molecular heparin of 2 milligram per kg, 1 to 2 milligram is that recommended dose. So we use sometimes 1 milligram per kg, sometimes 2 milligram per kg. It's but because it's very difficult to take exact amount, because 0.6 ml contains 60 milligrams. And then we need to take it in insulin syringe separately. So it is the calculation varies between 1 to 2 milligram per kg. And for this particular child, we gave this for 5 days and IV immunoglobulin given for 2 days. So this was the X-ray on day 5. We started. X-ray showed bit worsening subsequently, but in terms of requirement of ventilator support, even though X-ray was looking a bit worse, the ventilator support came down on day 6th. And initially it was pressures were 19/6, and then we gone up to 18/6 bit, but oxygen requirement has gone down to 30%. So here again, initial clue about the inflammatory markers and subsequently the response to the therapy had boosted our confidence that we are dealing with an inflammation which is maybe related to maternal COVID infection. And we did all the supportive care like IV fluids, antibiotics, and dopamine. As I said before, we gave it for a couple of days. And child responded very nicely, and response was seen after 48 to 72 hours of therapy itself. So platelets immediately gone up. From day 4, platelets were 1,11,000 and D-dimer has gone down to 1,474. So to summarize all these reports, so in this particular case, because we could identify this case at quite initial stage, where the CRP was 60 on day 4 and day 6 it was 67, but drastically CRP came down till it took nearly 3 weeks to get to normal range. And for the D-dimer, which was in the range of 6,483, for in 5th day after the starting the therapy with low molecular heparin, it dropped down to. So early initiation of treatment has prevented child going into complications of DICU, which we have faced in the earlier child. But fortunately, that child was stable hemodynamically, so could stretch for quite longer time. And so we were, after this, child was extubated and was looking better. I tried to get the rashes, but rashes were gone by that time. And child was doing well after 3 days of IV, 2 days of IV immunoglobulin, 3 days of methylprednisolone, and child was on low molecular heparin, where the levels of D-dimer we monitored continuously. Once it came down below 1,000, we stopped low molecular weight heparin. So heart rate normalized on 5th day. So we picked up the child on day 3. After 2 days of treatment, heart rate came to normal. We was extubated and then on oxygen we kept for a couple of days, antibiotics given for 10 days. For stabilization BP, as I said, we gave inotropes 4 days, and feeds were started and established in the next couple of days and required phototherapy for 2 days. So what we interpreted after that is that conduction abnormalities may be the earliest presentation of MIS-N, because that time, I think in Kolhapur, we had, every unit had at least 1 or 2 cases of MIS-N with a different presentation, predominantly cardiac presentation. So our cardiologist, Dr. Ravi Pawar, was very quite confident that as soon as we tell him that it's a bradycardia, he used to say, just look for antibodies. So it was so he was so confident. So we just evaluated immediately for this child. All the neonates with a known case of maternal COVID to be monitored for heart rhythm for initial 1 week. Early initiation of standard MIS-N treatment along with other supportive care helps early recovery and avoids other complication of MIS-N. It leads to diagnose and treat as septicemia, so worth identify at early stage. So instead of sticking to one diagnosis, that septicemia or septic shock or some infection, we should think out of the box, especially in this pandemic period, that we may be dealing with inflammation rather than infection. So this is the child we had recent follow-up, and the child is growing well and is doing well in terms of neurologically, as well as growth is normal. And subsequently, we had 9 cases, and all were like preterms and between 32 to 34 weeks, and 2 pair of twins in that. Majority had unexplained bradycardia on 2nd or 3rd day of life. And because these neonates were already admitted for prematurity and low birth weight, we could easily monitor them. And 3 neonates required inotrope support, and 4 cases we knew had maternal COVID status positive during the 3rd trimester, and all the neonates were admitted for preterm care. So here, it was when they admitted for premature care, we were monitoring them daily. We were not knowing that mother had COVID in most of the cases, but when the child develops unexplained bradycardia, we were quite suspicion, and then subsequently we did evaluation by antibody and inflammatory marker. So this was the typical picture. I had 10, 12 picture like this, that in the middle of the night, nurse or medical officers used to send us the picture. When they call us and says heart rate is 75, so we said, oh, this is wrong. Just check with the ECG, just check the probe. Child may be moving, and child is otherwise stable, active, crying, saturation 100, but heart is 75. And that's how in subsequently, I had one video as well. This was the saturation is 100% with good respiratory effort, and heart rate was 70. So we made the child to cry and then see what happens with the heart rate. Not much difference. So we were quite sure without any paper ECG, it was very difficult to get paper ECG all the time. So just with a routine monitor and multipara monitor and the way the child is behaving, we were quite confident that we were dealing with a heart block. So just to recollect our basic knowledge, the first degree heart block is when the PR interval prolongs, but without any missing of QRS complex. Second degree heart block type 1 is when PR interval increases gradually and then we miss one QRS complex. Second degree heart block, it can be 2:1 or 3:1 block where every third or every second heartbeat is missed. And so most of the cases we have seen is like type 2 heart block. Third degree heart block is a complete heart block. So inflammatory markers were raised significantly in all the cases. But when we had initial clue that this could be a bradycardia, CRP is high, and maternal COVID antibody and neonatal COVID antibody came positive, we didn't do all the investigation in this preterm neonates because blood sampling, it requires a lot of blood and it's very difficult to interpret once we couldn't, because every time once we try to send a couple of inflammatory markers, lab is to say send repeat sample, or there's an error, or sometimes values were very, very erroneous. So we did only selected samples, inflammatory markers, and we were, after treating initial couple of cases and with the experience from other units, we treated all them with methylprednisolone, IV immunoglobulin, and low molecular weight heparin, depending on the D-dimer levels. And we had, I would like to, I will summarize all this again. And we had a very recent case here. It's a full-term newborn was LSCS, persistent abdominal distension on day 1. I didn't have X-ray of this newborn. And day 3 diagnosed with intestinal obstruction. Was admitted in a surgical unit, and there was mid-cut volvulus causing obstruction, and resection reanostomosis was done. This was the per-operative picture, and there was a big volvulus with a gangrenous segment which was resected with good healthy ends, and anastomosis was done. And pediatric surgeon Dr. Kaddu is a very eminent pediatric surgeon. He said the anastomy is good, and usually the child expected to recover very nicely. But the baby was referred to us on day 9 because child continues to have low blood pressure and oxygen requirement. On admission, we had hemoglobin of 7.7 because per operative, a lot of blood has been lost. So we thought could be anemia as the cause. So correction was done by blood transfusion. And we shifted on to higher antibiotics. It could be an infection post-operatively and maybe have pneumonia. So we continued with higher antibiotics. And as the bowel movements were normal, child was already on 5 ml, 3 ml of feeds at that time. This was the investigations on admission to our unit. Day 6, they had one CRP, which was 54. Considering the post-operative period, it was thought it is just could be inflammations, but child was on higher antibiotics. Day 9, when we got the child in our unit, hemoglobin CRP was 76. Total count was 22,100, hemoglobin 7.7, and D-dimer level was 5,350. So we did evaluate after initial report. came 22,100 and CRP 76 on higher antibiotics. We did other investigations on the same day and D-dimer was on the higher side. Still, again here dilemma, because it is a post-operative period, some inflammation is quite likely and D-dimer is not that very high. So we kept monitoring for another day. Subsequently, WBC count has gone to 34,000, neutrophils are 80%, platelets dropped to 78,000 and D-dimer has gone up to 8,040. So here, when we checked retrospectively with the mother, she had COVID infection in the pregnancy, and we did the antibody level, which is IgG positive for the baby. So child was started on, so both were positive, child was started on the regime, but here, child hemodynamic condition, oxygen requirement remains same in spite of blood transfusion and higher antibiotics. D-dimer is high, antibody positive. So we gave IV immunoglobulin and low molecular heparin and didn't give methylprednisolone because all the time we were worried about infection. And we're not very sure about whether it is a mis-N, but child responded and showed very good recovery after 3 days of treatment itself. Child came off oxygen, came off inotropes, and D-dimer has dropped down very quickly. So mis-N may be the cause for delayed recovery and persistent symptoms, as response was very prompt to IV immunoglobulin. So we are not saying that all the time they responded well means we are at correct, but whenever there is a doubt and whenever there is evidence that there is a IgG antibody is positive and child is not responding to a routine care, it's worth exploring these possibilities. In summary, so far we have seen in our unit in that last 9 months period around 12 cases. So maternal symptoms were present in only 2 cases and most of them were asymptomatic. Most of them were cesarean delivery and gestational age of presentation was 34 plus 2 weeks in median range and 32 to 37 weeks was the admission we had. Only 2 neonates in that were in above 35 weeks. Birth weight was 2.1 kg and 40% newborns were had history of intrauterine growth retardation. 9 were male, 3 female, and 2 pairs of twins. And age of presentation were between 1 to 5 days. It's very important because most of these preterm neonates were admitted in our unit. We could identify them at early stage because it's a bradycardia. We didn't wait to see any further complication because we gone through a lot of stress with that previous child going to the DIC and bleeding. So we were very vigilant and treatment was started earlier, and there was no standard guideline whom to treat with IV immunoglobulin and whom to treat with just methylprednisolone. So as a routine, we treated all of them with both methylprednisolone and IV immunoglobulin. In terms of organ involvement, if you see this graph, cardiac involvement was seen in 91% of cases, respiratory complaints in 50%, GI bleeding in 2 cases, and CNS, 1 child had some query convulsion type movement, and cutaneous lesions in 2, and 2 children had fever. In terms of clinical profile, fever and rash in 2 cases, but predominantly 75% had bradycardia, and 66% had thrombocytopenia and respiratory distress in 50% of cases. And coronary dilatation was seen in 1 case. Sorry, it is 1 case. And we had 4 neonates who presented, who had a shock and required inotropic support initially. Here, the respiratory distress and thrombocytopenia could be a part of prematurity itself. So it may be just prematurity may be causing all this problem, but considering this COVID positive and the way we are treating, we thought these symptoms could be related to post-COVID inflammation. So in terms of cardiac, out of these 12 cases, 9 had arrhythmia in terms of 2nd degree heart block, dilated coronary in 1 child, which responded well after therapy. And after that, we had 2 scans, which were normal. And then we have shock and cardiac dysfunction in 4 cases. And these were the children's. We kept a register of all these neonates. So far, we have in our unit cell, after these cases, we had another 10 cases so far. So we have kept the registry and we kept close monitoring because we don't know how they will behave in future. And all these were doing really well. for the given age, and neurodevelopment, everything looks normal for them. So recently, we have published about 20 cases of neonatal Miss N in Children Journal, and it was compiled data of all the 7 units in Kolhapur, and data was it was very tough task for everyone to collect the data. Dr. Ravi Pawar, our eminent pediatric cardiologist, helped us to get all the data, and we reported this in one of the good journal. And so I will just quickly summarize about this article. This was from September to March period in last year, September 2020 to March 2021. So what we are talking about is Miss N, that is that mother is infected with COVID and the child develops the symptoms of inflammation without any active COVID infection. There are other possibilities and other symptoms we see is like active COVID infection newborn, that is a late onset neonatal infection or early onset neonatal COVID infection, or sometimes the late onset could be because of contact with other members in the family rather than directly getting it from the mother. So the incidence of direct transmitting infection from mother to neonate is very, very less. All the time any child develops any symptom, or if any child develops symptoms of high-grade fever or any problem, RT-PCR we should do as a routine to check for any active infection. But if RT-PCR is negative, definitely we should go for antibody testing. This was the initial, because CDC has no definite guideline or definite criteria to diagnose Miss N. The first time in this journal, we put the terminology as multisystem inflammatory syndrome in neonate, secondary to maternal SARS-CoV-2. So I will just go through what are the changes we suggested or we highlighted in this article is that any neonate who is born less than 28 days at the time, who is less than 28 days at presentation, laboratory evidence of any infection in the mother, which is confirmed by RT-PCR, or symptoms consistent with the SARS-CoV-2 infection during the pregnancy, because it is not only the RT-PCR, sometimes the CT scan and the rest of the reports will guide us. And COVID-19 exposure with confirmed SARS-CoV-2 infection during the pregnancy. And then other way around is retrospectively when we see a newborn with the IgG positivity without IgM. This could be because of maternal COVID infection. That again suggests it is a COVID infection during the pregnancy. Second criteria we took is that severe illness necessitating hospitalization, that is neonatal ICU admission. In pediatric, the 2 or more organ involvement is mandatory, but here, because predominantly cases we have the cardiac conduction abnormalities, so at least if the child is having any cardiac conduction abnormalities or coronary dilatation aneurysm should be considered very significant instead of considering 2 organ involvement. Third, any elevation of inflammatory markers, either of multiple parameters. So routinely we check for CRP, we check for procalcitonin, D-dimer. So any of the elevation of these inflammatory markers with clinical evidence should be an inflammation. So during the study, we excluded those neonates who are having birth asphyxia, because asphyxiated neonate will have erroneous inflammatory markers and very difficult to interpret. Second thing, we excluded those who are having culture growth or any bacterial growth, and then as a caution, because if the mother is having any COVID autoimmune disorders like lupus or any autoimmune disorder that can affect the cardiac conduction in the fetal or neonatal period. So these neonates were excluded. So in our practice as well, when we say the child is having bradycardia, at the same time, we should think of other possibilities and they should be ruled out. So you may be dealing with some electrolyte disturbance. So all the time when we saw the bradycardia or any, so we did check for electrolyte, calcium, everything. Well, most of the cases we documented with a 6-lead ECG and have paper documentation about cardiac problem, and should have some cardiologist friend to be around to interpret these results immediately so that action can be taken earlier. And ECG we get very quickly, but other parameters in terms of blood investigation, it takes long time, at least 24, 40 hours, 48 hours to get all this report. So meantime, if you have slightest doubt and you are very confident with other circumstances like antibody positive, child is not behaving normally, then it is worth starting treatment till you get all the results. So this was the ECG in our article, and you can go through the article later on. So definitely showed a good improvement after IV immunoglobulin and steroids. So summarize about that 20 cases in that article, cardiac involvement was there in 90% of the cases. We had 10% had, like 2 cases had thrombus. In fact, IVC thrombus was there, and one child has thrombus which was present in the heart as well. So it required thrombolysis, and a child required low molecular heparin for quite long duration. And one child had, 2 children had GI bleeding, and respiratory support was required in 55% of cases, GI complication in 30%, and neurological complication in 10% of cases. Fever and temperature instability was seen in 2 cases. So in terms of investigations, though all the parameters were significantly elevated, to be when we look at D-dimer, which is in the range of 12,000, we have seen the maximum D-dimer level, and NT-proBNP, which was above 30,000 in a one neonate where there was a thrombus in the IVC. And blood culture, where repeat blood cultures were done during all these neonates, because I think at least 1 or 2 or 3 blood cultures were
It's
sent
17 hours.
during the treatment period, because we all the time this will confuse, like especially preterm neonates, sepsis is very common. We tend to think infection, antibiotics, we tend to upgrade the antibiotics, but it is worth to have a good blood culture, and you should be very confident about your blood culture report. If you are feeling very confident it is not it is a properly taken blood culture and still not growing anything, then we need to think it's some other problem rather than routine infection that we see in our neonatal ICU. So cardiac wise, out of that 20 cases, one arrhythmia, like 44% has a second degree block, dilated coronary in 2 cases, intracardiac thrombus in 2 cases, shock and cardiac dysfunction in 5 cases, and one child had 1 thrombus in the left pulmonary artery, 1 in right atrium. So all these neonates, as I said, received the same kind of therapy, and few required a lot of inotropic support for initial stabilization, and 2 children died, one due to necrotizing enterocolitis and other due to multi-organ failure. And these were presented to us quite late. This was presented quite late, and we attribute this to delayed diagnosis, because at that time nobody was very much aware of the things, and many a times in Kolhapur we do get the neonates from the periphery where they were treated with the infection or sepsis part, and when they landed here with the severe infection or landed here with severe necrotizing enterocolitis or multi-organ dysfunction and DIC, it was very difficult for us to revive, and 2 children died during that time. Recently, eminent infertility expert in Kolhapur, Dr. Satish Patki, he's doing a significant work in analyzing and understanding about placental pathology in this COVID positive mother. What interesting, it was found that this is going to be published in one of the good journal in a couple of next month. So what he has found that mean capillary villus count in placentas of COVID-19 infected patient is found to be significantly low as compared to that of observed control. And majority of the villi in the placenta of patients who had serious form of COVID-19 were completely avascular. What does that mean? Is that that involvement of syncytial layer of the placenta has caused significant damage to that layer, and then it caused a fibrosis, and subsequently the number of capillaries in the fetal side is significantly less. That's why the incidence of intrauterine growth retardation or intrauterine death, as well as prematurity delivery incidence, has significantly gone up. So this is the histopathological reporting of 16 mothers, and 1 neonate died at 30 weeks. That was not neonate, it was intrauterine death at 30 weeks, and cause could be because of maternal COVID infection. So we have one more recent publication in Journal of Pediatrics. that fetal inflammatory response syndrome associated with maternal COVID-2 infection. What they have found, it is not only the placental, sometimes fetus will show signs of inflammation. So perinatal fetal distress is a potential complication of neonates born to mothers infected with SARS-CoV-2 and may be associated with otherwise unexpected preterm birth. So, and then subsequently autopsy finding in this neonates fetuses showed that elevated interleukin-6 concentration as well as C-reactive protein and plasma concentration of TNF-alpha and other inflammatory markers. That means it is not only the inflammation we see in the immediate post-neonatal period, similar kind of picture can come in a fetal period as well, and they may not survive or they may not, so they may be declared as intrauterine death. So one of the cause of IUD could be the fetal inflammatory reaction. So this also we need to consider when we see a lot of IUDs or a lot of preterm deliveries. So a lot of case reports have been done and randomized trials has been done. What they have found pre and post COVID era is that pattern of higher rates of miscarriages, preterm birth, preeclampsia, and perinatal death has observed in women infected with one of those novel coronaviruses during the pregnancy. So the problems with mother, any medical problems has increased incidence, as well as problems with preterm deliveries has gone up, and those who deliver to COVID-19 mother, the morbidity and mortality is very high among those neonates. So this is one of the recent report in a JAMA Pediatrics. It is about maternal and neonatal morbidity and mortality among pregnant women with or without COVID-19 infection. It is head-to-head comparison study. And what they found, COVID-19 in pregnancy was associated with consistent and substantial increase in severe maternal morbidity and mortality and neonatal complications. So we have few case series about, so we talked about GI complication, everything. There's hematological complication as well. There are 2 case reports about hemolysis, which was not explained by anything, and these children responded after methylprednisolone. And we too had one child with hemolysis, but we could not do extensive evaluation. But that child had antibody positive. So this year they did all investigation, look for any autoimmune hemolysis, but ultimately no cause was found, and the cause attributed to the SARS-CoV infection during the pregnancy. Recently, one more report in pediatric infectious diseases about child who had persistent pulmonary hypertension and was not responding to routine care, and the child was treated with the same regime of methylprednisolone and IV immunoglobulin and showed good response after 3 days of therapy. So a lot of reports all over the world about with the different manifestations, it's like lot of vigilance is required to diagnose these cases, and it's very important that we must report these cases so that we have adequate clinical data what's happening with this newborn. When we have presented a lot of said why can't it be some autoimmune condition, so when we look at the literature, there's only one condition which can mimic like this, that is neonatal onset multisystem inflammatory disorder. But this particular condition is inherited one, it is autosomal dominant, and then it is genetically mediated, and predominantly it is a skin involvement, and as the child grows they will have problems with the central nervous system, skeleton, and then GI system. So these cases are very, very rare, and they were not that sick. So it's easy to identify it if it is just an inflammatory disorder. So always we need to think differential diagnosis all the time. But considering this COVID era, and now just we have finished our second wave of COVID, so we are expecting similar kind of cases coming up in a couple of months. So take-off message is that in this present pandemic, many mothers are infected with COVID and many are asymptomatic. Neonates can present with respiratory distress, shock due to immunogenic reaction, which was initiated before delivery. So we may not be completely aware of these things. Late neonatal reactions can complicate existing clinical condition, which can only be diagnosed with high suspicion of this condition. As many had bradycardia, close monitoring of known case of maternal COVID for neonatal heart rate at early at least in the first week of life, so that we can diagnose cases earlier. Prompt diagnosis and early intervention can definitely help for good recovery. We may see completely different new manifestations as well. So we need to be very vigilant. And now, because of vaccination, trend may completely change. We may see lesser number of cases, or we may see different kind of presentation. So we need to be very vigilant. So because of this experience with nearly around, still now nearly around 18 to 20 neonates in our unit itself, and total around more than 40 cases all over the Kolhapur, we thought that we should have some good unit policy, especially in the institutes where the delivery rates are very high. Send COVID antibody in any preterm neonate, those who are admitted without any documented history of COVID at the earliest, so that we can suspect miss-send at earliest. If the child is admitted preterm and without any obvious cause, if it is just the fetal distress or it is a rupture of membranes, then we consider doing antibody at the admission, so that we can keep close monitoring them. And so far, we have around 12 neonates who had COVID antibody positive. And unfortunately, though 26 to 28 weeks, 3 neonates we lost recently where COVID antibody is positive, and they died due to DIC. I'll be collecting the data, and if possible, I will have more detailed discussion sometimes. So it is not that all the time we may see the clinical manifestation step by step. Sometimes they may be born very sick. So they may not respond to your therapy as expected, even like when we give surfactant, when we give inotropes, usually preterm neonates, they do become a bit stabilized, and they, even though they may not be very stable, but they show some signs of recovery. But the neonates which we were lost in last month, they were completely different. They just not responding to any kind of therapy. So we are expecting that we may face this kind of situation in future as well. Close monitoring for heart rhythm for first 1 week in known case of maternal COVID for those neonates who are not hospitalized. Any neonate with a very high CRP above 50 and thrombocytopenia with culture negative, evaluate for antibody and other markers. It is very important. So any infection we suspect, make sure you are really dealing with infection. Otherwise, many a times in a busy practice or in institute level, it becomes that we may not do all the investigation. We continue to treat with antibiotics and end up with complications. Parental counseling at the time of discharge from the hospital for close monitoring for at least first 2 weeks of life. If we know mother is COVID positive, please counsel the parents that we need to be closely looked at. We need to look at the child for feeding, growth, all the parameters, have frequent visit for at least couple of weeks, so that any complication should be identified earlier. I think that's all for the day. Thank you very much.
Thank you, Dr. Vijay Mali, for that wonderful presentation and sharing all your experiences. I think it is really, an eye-opener to many pediatricians that we need to have a high index of suspicion and think of Miss N whenever we don't see the usual parameters, a shock not responding or the heart rate coming down without any reason, or a child, not behaving in the normal way, especially when you have COVID positive mothers. There are some questions here, I would like to ask something. See, you have had so many cases of heart blocks and 1 or 2 coronary dilatations also.
Yes,
do you have a follow-up system now regularly for them for evaluation with either echo and ECG? Or how long did it take for the heart rate to come back to normal? And
Madam, they responded 48 to 72 hours, almost all responded nicely. And in that, I have presented that after 2 days, most of the heart rate came to normal. There was a regular rhythm. But every child in our series received methylprednisolone and IV immunoglobulin. there's always a debate whether just involvement, cardiac involvement, whether we should give immunoglobulin or just give methylprednisolone. But here we treated them with both the medicines, so we don't know which one has helped them, but they responded very quickly.
I think many protocols tell that we have to use both nowadays. And I don't know whether it is only myocarditis that is causing this, or is it?
So this is like conduction block, madam. This AV node
Okay.
and conduction system is involved. There was a myocarditis with elevated inflammatory markers. They were in shock as well. So say what we have learned so far, it is predominantly involvement of the conduction system.
Okay, so you don't need a follow-up then.
No, we have just route because they stabilized on third, fourth day. And
not like Kawasaki's disease where you have to follow them up regularly.
We did the echo, madam, as per the protocol. After 1 month, if the echo was normal initially, one echo was done after 1 month, and otherwise we haven't kept any follow-up, just the routine examination in our clinic.
There are some questions. What were the indications to start low molecular weight heparin?
Yeah.
And in spite of having a low platelet count, I think
D-dimer level. Because,
are we chasing the D-dimer or?
It's a D-dimer level. Without any bleeding or any other complication, if D-dimer levels are above like 2,700, we just treated, because many children with D-dimers gone up and they ended up in a bleeding. So we just want to stop that catastrophe later on. So we treated with low molecular weight heparin from the beginning. And if the levels were low, we kept close monitoring. And after 48 hours, we repeated the D-dimer level. If it is rising, all children received with low molecular weight heparin.
Somebody is asking, because the cost of investigations is very high, can we think of, I mean, what low cost investigations would you advise as inflammatory markers for COVID? So, we C-reactive protein, I think, CRP. Is available because it helps to guide. Minimum CRP has to be CRP inflammation. D-dimer we suggest, because if we just miss that D-dimer and child develops any thrombosis, especially we had with IVC thrombus and thrombus in the heart, these are very difficult to treat. And necrotizing enterocolitis we have seen in the term neonate, that could be because of decreased perfusion to the gut. So it will mislead if child start developing complication because of thrombosis. It will mislead us to treat indifferently. So always good to do D-dimer so that we can prevent some complication. Rest of the parameters is like for cardiac purpose. We know there's a conduction block. We did it because we wanted to know what's happening with all of them. So as per the convenience, we did like troponin I and anti-BNP, because once we realize that is mainly conduction problem or cardiac problem, we want to know what else is happening with the heart. So that investigations were done during that time. So we suggest CRP, D-dimer is must. And if there is a shock or any significant cardiac problem, good to do cardiac inflammatory markers. I think first clinical suspicion is most important. As I said, unexplained shock or DIC, or as he said, bradycardia, unexplained respiratory distress. When you see that the X-ray is not suggestive of RDS or pneumonia, high index of suspicion in any mother who is COVID positive is, I think, important. And in them, CRP and procalcitonin to differentiate between bacterial and COVID can help you. Procalcitonin will not be much raised here. Yes, when compared to, but CRP is very high. Yeah. So that should make you suspect that this could be a COVID. And ECG, of course, will help you if you don't have the other investigations. So only worry, like we should get paper ECG properly done, because in terms it's difficult. And then even having the neonatal leads difficult, then it's good to have some at least multipara monitor. Yeah. Any other questions, Bhavna or Dr. Salgare?
Madam, there are few in chat box, I think. So.
Yeah, I just saw the chat box.
Ma'am, a comment. Hello.
Hello, yes. Yes,
I'm
Swapnil.
Dr. Yeah, just a comment regarding a surgical case, ma'am. Like a bowel gangrene in a neonate secondary to volvulus.
Yeah.
In most of the bowel gangrene, sir, whenever the, like, especially like volvulus or like interception, when there is a gangrenous part, and as soon as we release that part, there are toxins in the gangrenous bowel or the vessels which get released into general systemic circulation.
Yeah.
And because of that, most certainly there will be a post-operative toxemia or like systematic inflammatory syndrome like phase. Due
Yeah.
to that, also D-dimer levels, CRP levels might get elevated, and
Yeah.
patient will have a similar toxemia picture. So it will
Yeah.
be difficult to attribute the same with the MIS-C. Were there any other features other than in that patient?
Yeah.
Patient?
So that case, like we were not very sure, but this child, the
Hello?
gangrenous, so the gangrenous bowel was completely resected.
Hello?
Hello.
Yes, Swapnil, can you hear or no?
Hello. Am I
Hello?
audible?
Swapnil, we can hear you. And Dr. Vijay Mali is also audible.
So in that case,
Yeah. So were there any other markers other than inflammatory markers, whether elevated in the post-op period?
This was like a routine surgery, and they didn't release that. In fact, it was completely gangrenous. So that segment was completely resected.
Hello?
So if it
Yeah,
is
yeah.
just
Hello.
because it was completely resected, and the child was otherwise stable after that, but usual recovery after 4 to 5 days, they show good recovery, but instead the child continues to show deterioration, oxygen requirement, inotropic support requirement. So we did all this marker, and there was no reason that D-dimer should continue to rise.
Okay.
And we are not attributing that inflammatory reaction has caused this gangrene or volvulus any problem. It could be some add-on complication, or maybe it is a coincidence that child had gangrene and subsequently developed this inflammatory reaction. So it required long time for the child to recover.
Okay, okay, sir. Okay, sir.
Unexplained rise in markers should always make you do the IgG and then make a diagnosis. And one thing I think very pertinent point that Dr. Vijay Mali has brought out is, yes, there have been some genetic studies being done which show the genetic predisposition also to C and MIS-N, both of them. So I think that is another field of interest for everybody to look into. So if we pool all the cases and look at the genetic markers, I think I'm sure we'll come up with at least when to predict.
Yes.
In whom to predict.
So we are doing, madam, now, like we are collecting data for all the preterm neonates. We are doing all antibody for everyone, and we are just following it up, what will happen to them. Because here we couldn't, because it is just, we diagnosed and retrospectively we found out, so we don't know actual incidence. So it may not that all the children will be suffering from the same problem. It may be very less incidence, but it is good to have more data and more compiled data from every places.
Yes, Bhavna and Dr. Salgare, any questions are left? The chat box.
Dr. Vishwanath has asked, madam, any update on MIS-C?
Pardon?
Is there any NNF guidelines?
NNF
guidelines on this MIS-C?
So there is
some guidelines are there.
No, sir, as such, there is no, the only thing we need to be there is no such guideline from NNF as yet. But in fact, it was said that we are over-diagnosing these cases, over-treating these cases. So
there are there are protocols, I think, from AIMS and others for management of MIS-N. Of course, they also the stress is mainly on clinical, but investigations have got a very little role to play as far as diagnosis is concerned. And respiratory distress and oxygen requirement without any, because even X-ray does not have a great role to play here.
Yes, madam.
So doing the IgG, and if they're positive and if these things are there, we have to suspect misin and treat them. There are protocols. Sir.
So what they said that we should strictly follow the diagnostic criteria, not because what happens, we have some flu and IgG and methylprednisolone is easily available. We should not just jump and start the treatment. That will give false, sometimes it will confuse all the picture. So we should be very, very sure before we start the treatment. That is the now standard guideline, because all this we did initially because there was no other option we had. And nowadays, whenever we go detailed evaluation, but we are very sure that these cases are there and they are there everywhere. So only thing should be picked up at the early stage.
Thank you, sir. That was very informative, and we really appreciate and thank you for taking out time for us.
Thank you.
And as there is a lot of overlap between the syndromes, like PPHN can be seen in perinatal asphyxia could be due to COVID. So there is a lot of overlap between the cases, sir. Even they mimic sepsis, but delayed recovery is one thing which we need to look on, sir. Usually they do not recover with our routine antibiotics, children. So thank you very much. And I thank Manchetti madam also, being so busy. She has agreed to us and moderated the session. I thank our president, Dr. Salgares sir, for always motivating us and keeping us on our toes. And I thank all our seniors and colleagues who have joined the session and made it successful. Thank you. Thank you, one and all.
Thank you.
Thank you. Thank you, madam.
And give my regards to Dr. Pawar. I'm happy that he is doing good work there.
Yes, sure. Thank you, madam. Thank you, sir. Thank you. Thank you.
Thank you.
Sadhu also.
Yes, madam. Yes, madam. I will inform them. And in future, if we are planning for breast milk bank, we will visit there, madam.
Yes, please do. Thank you.
Because we need a lot of help to start this bank.
Definitely. We are all there.
Yeah.
Thank you. Thank you.
Yes, sir.
Thank you.